Good afternoon, everyone. Welcome to St. Luke's Rehabilitation and Movement Science Grand Rounds. As a reminder, please scan the QR code to get CME or CE credit. Today, we have Dr. Kyle Bradley and Dr. Stephen Kareha to discuss from generalist to expert, the value of residency and fellowship training. Dr. Bradley earned his Bachelor of Science in Business Administration and subsequently a Doctor of Physical Therapy from Misericordia University. He received his residency training in orthopedics from St. Luke's University Health Network. He is board certified in orthopedic physical therapy. In addition to his practice in orthopedic physical therapy, he has completed extensive research on the value of residency and fellowship and has presented on this topic nationally. Dr. Kareha graduated from Gettysburg College with a bachelor's degree in health and exercise sciences with an emphasis in athletic training. He received a Doctor of Physical Therapy degree from Arcadia University and then completed his postgraduate training at Allied Services in Scranton, PA, with an emphasis on back and neck injuries and vertigo. He then earned his PhD in physical therapy at Nova Southeastern University and is board certified in orthopedic physical therapy. He is director of the Orthopedic Physical Therapy Residency Program and director of the Spine Physical Therapy Fellowship for St. Luke's University Health Network and assistant professor, clinical associate in the Department of Physical Therapy at DeSales University. His research interests include enhancement of care, physical therapists in primary musculoskeletal care, psychologically informed care, and health services research.
All right. Excellent. So welcome, everybody. Apparently I can't get this to work. There we go. This is our statement of need, and the target audience of this talk is for all providers. This is our designation statement. And while we have nothing financially to disclose, I do want to just point out, as Dr. Bays mentioned, that I am a program director for residency and fellowship, which in this presentation I tried to remove my bias, but I'm sure you can hear my bias throughout the entire presentation. Today what we're going to do is we're going to talk about postgraduate training, how that postgraduate training changes clinical decision-making, develops specialists, and the impact on professional development as a whole. So to better understand where we're coming from, we got to look back at the 20th century and into the 21st century of how patient expectations have changed. Starting in the early 20th century, people going into hospitals and seeking medical care in outpatient centers began to become more complex. People became sicker. More technology was necessary, which also increased the consequences of error. As medical knowledge and as research knowledge enhanced, there was a growing need for more specialized care and greater knowledge of the people providing that care. So because of that, in the 1940s, specialty boards in medicine began to develop. They began to develop with the intent to decrease the variability of how medical providers became specialists and also to enhance quality of care while decreasing unwarranted variability in practice. The last specialty to require residency training to achieve specialty in medicine was family medicine, which converted the traditional general practitioner to family medicine as the center point for patients seeking physician care. So during all of this, there also became a growing need for more specialists, more patient care demands. Family medicine was seeing people with who were sicker. And at the same time, physical therapists were also seeing the same thing. During the same time frame, inflation occurred. And patients' expectations have changed, not only with what they should expect out of the amount of specialty knowledge that a provider has, but also they're paying more in copay, coinsurance, premiums, any of that aspect. Because of all those aspects that were not only affecting physician care, but also affecting the physical therapy profession as a whole. As we as a profession realize this, our profession has also, physical therapy profession has also evolved. Initially, we didn't need as much knowledge, and so it was a bachelor's degree only that you needed in order to become, and then licensure in order to practice physical therapy. But as the body of knowledge that new graduates needed to know increased, it changed to a minimum degree of a master's degree. And then again, as the body of knowledge that was required grew, it then evolved to requiring a doctoral degree, which is where it is today. This produces wonderful generalists. But as I mentioned in the last slide, there is a need for a growing need for specialized expertise, which birthed specialty certifications. Now, I will mention that, and we'll go into this a little bit later, specialty certification, you may be thinking, well, don't all physical therapists see orthopedics and that's just what it is? That's not exactly true. Physical therapy is much broader than just orthopedics. And we'll touch on that a little bit later. Throughout the majority of the 20th century and 21st century, the primary method for developing that expertise and getting better at your craft is continuing education. While that's wonderful, and in 2009, a study did find that it does improve self-efficacy, and it also improves knowledge. The problem with continuing education is it had limited long-term skill retention. So the general impact of continuing education is you learn a lot of stuff in a weekend or a week or over a course of a semester or a day, depending on how long that CE program is or CME program is. And this goes beyond just physical therapy, by the way. You end up doing and seeing in your patients whatever you just learned consistently throughout that next week. Effectively, when you are a hammer, everything looks like a nail. But after that week, it tapers off. The other thing is, since everybody looks like a nail, and then it tapers off back to what you used to do, it has been shown to have minimal impact on patient outcomes. So that brings to question, what actually does enhance physical therapy practice? A systematic review published in 2020 found, again, that it does improve knowledge, but CE does not change practice patterns. In order to change practice patterns, you need to add in peer assessment or mentor-patient interactions, and ideally both. So that brings to mention about mentorship, because that is that peer advice, that peer feedback. A study in 2006 found that mentorship, when added after a continuing education or CME course, was superior to CE alone. That mentorship helped the clinicians integrate the new knowledge and use it more consistently in the right way, and then be able to follow up with those patients in the best way possible. So skills were better integrated and the patients had better outcomes. So that brings up board certification, which helps physical therapists or physicians or any medical provider specialize in a specific area of practice. In medicine, residencies are required to become board certified in a specialty. In physical therapy, it is not a requirement to go through residency in order to become board certified. It is an option, but it is not required. Right now, as we speak, only 15% of physical therapists throughout the United States are board certified. In order to become board certified, you need to demonstrate advanced knowledge. As I mentioned earlier, physical therapy is a very broad profession. It covers a new graduate, a new DPT gets education in acute care, clinical electrophysiology, neurology, pelvic health, wound management, cardiopulmonary care, geriatrics, orthopedics, sports, pediatrics, and oncology. Board certification is for those people who are able to demonstrate advanced knowledge in one of those areas. And just like with medicine, you can be dual boarded as well. To become board certified, there's no formal mentorship required. And as I mentioned, residency is one option, but it's not the only option. So does that make you an expert? Well, early studies in the early 2000s found that yes, it does seem to improve patient outcomes. Unfortunately, follow-up studies found that that is not the case. Otherwise, this would be the end of the talk and you guys could go home. So how do you make a provider an expert? Well, let's first look at what expertise is defined as. Studies in the late 20th century, early 2000s, and up till now, specifically one that was published in 2003 and another one in 2021, found that expert physical therapists demonstrate enhanced clinical reasoning, they have better patient outcomes, and they have improved therapeutic alliance. So what does that mean? Well, they are able to become more efficient at figuring out the problem and getting to the solution, which then allows the patient to get better faster. And a big term, therapeutic alliance, it's the interaction with the patient. It's the trust you build with the patient. It's the patient's understanding of what you're doing and your understanding of what the patient is doing. Making sure you are both on the same page. And there are numerous studies that in multiple branches of medicine that have found that therapeutic alliance is vital to improve patient outcomes. So how do you acquire this expertise? Well, studies in multiple areas, and I like this study especially because it's from a non-medical area. It's from fighter pilots. But similar literature exists in musicians, engineers, physical therapists, physicians, nurses, a whole host of various professions. How you acquire expertise is after the activity, reviewing it, reflecting on it in a structured way, and having specific performance feedback loops. In other words, deliberate practice. And many of you have probably heard the term deliberate practice, but it's in essence, it's not practice that makes perfect. It's very specific, deliberate practice. Studies on expertise in music and in a number of other professions initially hypothesized that you need about 10,000 hours to become expert at something. However, further studies have found that that was actually a fallacy. It's more of the deliberate practice that you need to very specifically get that structured performance feedback loop and have those post-activity reviews from yourself, from a coach, from other people as well. So how do you enhance and provide deliberate practice on a consistent basis? Well, one way is structured skill development can be provided with classes, labs, didactic material. Focused feedback and progressive challenges and reflective practice can be provided with mentoring. And if you haven't figured it out yet, these two components are the two major pillars of what a residency is. So as I mentioned earlier, medical residencies are required. Physical therapy residencies are optional. Essentially, a residency is designed to develop a generalist, somebody who is a doctor of physical therapy, is trained in all of those different varying specialties of physical therapy, into a specialist in a specific specialty. Each year, only 12% of DPT graduates enter a residency. As I mentioned, it's optional. The curriculum as a whole is comprehensive as it integrates clinical practice with like classroom and education and specific mentoring that helps you integrate research. Residencies run from anywhere from 1 to 3 years, and there are numerous residencies throughout the country in various specialties. Fellowships are kind of the next level, and if you're familiar with the medical model, generally, physicians go to residency first, and then if they want to further specialize, they go into a fellowship. Physical therapy fellowships are similar. Again, they're optional. Fellowships take somebody who's already a specialist in one of those areas of specialty and makes you into a super specialist in an even more defined area of practice. This is the highest level of clinical training that exists today, and only 4% of all physical therapists in the country are fellowship trained. When surveyed, the biggest thing that fellows demonstrate is advanced clinical reasoning emphasis, better skill acquisition, better ability to figure out the problem with the patient and get them to the right solution quicker. The American Board of Physical Therapy Residency and Fellowship Education was developed in 1999, and since then there has been an exponential growth in residencies and fellowships. And this is wonderful. But there are a lot of concerns by people throughout the country and world of, is the juice really worth the squeeze? You know, we have a lot of people saying, well, where's the evidence? You know, what is the benefit beyond specialization? Is it just letters that you get? Because if so, what's the point? You know, right now there's two ways you can become a specialist. One is residency. One, you need to demonstrate advanced knowledge. The next one is a big one because burnout is an extremely important and massive epidemic throughout medicine right now. And people are concerned that the added stress of residency will cause burnout. There are concerns about quality of the mentorship, of the classes, of the residency curriculum as a whole, or fellowship curriculum as a whole. There's concerns about the cost of the residency or fellowship training. Organizationally, people are concerned that it only benefits the person going through the program. So, you know, is that going to have a ripple effect on anybody else? And they're thinking, well, maybe it won't. Maybe it's only going to affect that one person. So it's not going to help the masses of patients as much. Other people are concerned that it won't impact their career. And then again, organizationally, is it going to put too much demand on the faculty, taking them away from patient care? So the next couple slides I'm going to show you is research that has been done specifically to address some of these concerns. In 2023, this was published, so only about a year ago, looking at the clinical competency and job responsibilities between people who were residency trained, fellowship trained, and people who were not trained in either a residency or a fellowship. And what they found was people who were residency or fellowship trained had significantly better competency and confidence, especially with challenging patients. They took better ownership of their patient progression, making sure that their patients got to the right care at the right time more efficiently. Because, you know, if you're a patient, that means They're going to reevaluate you more frequently. They're going to reassess why you're coming in here more frequently. They're also going to reflect on patient outcomes more consistently, making sure that if whatever is going on isn't working, it will be altered. And if it is working, great. It'll be progressed at the right path, at the right frequency, so that you can get better faster. The other really important piece that came out of this study was there was a decreased feeling of being overwhelmed by workload, which resulted in a decreased risk of burnout post-residency. Again, I reiterate, decreased risk of burnout post-residency. And by the way, this wasn't just a small number. This was 2,000 people. And it looked at multiple programs throughout the country, throughout multiple regions throughout the country. A study in 2019 found that residency graduates showed superior diagnostic accuracy, and residency and fellowship graduates were more efficient at finding the patterns, at pattern recognition, so that they could clinically reason, diagnose the patient quicker, get to the right answer quicker, and help the patient get better faster. Study in 2008 found that people who graduated from residency and fellowships found themselves in opportunities of leadership and positions of leadership much more frequently, about 2 to 2.5 times the frequency of people who were not residency or fellowship trained. This study throughout the country also found that generally residency graduates had higher salaries than non-residency graduates and fellowship graduates. So that matches some of the more recent literature that has found that people who were board certified also have a greater salary than people who are generalists. There was also a greater educational involvement of these people who graduated residencies and fellowships. So this means that not only are they learning, but they're also helping their colleagues learn. They're also helping develop the other staff at their office, other students coming into the future, and people throughout their organization and throughout their region. So what about that person, though? Well, a study by Benson and colleagues in 2024 that has not yet been published surveyed residencies and fellowships throughout the United States. And it found that 73% of residency and fellowship graduates had increased job opportunities, and 96% had increased career fulfillment. I'm going to pause on the career fulfillment for a moment because physical therapy in general has a very high career fulfillment and job satisfaction level as a whole throughout the country, and relatively low turnover. So having an increased career fulfillment is phenomenal, because you could argue that there may have been almost a ceiling effect, that if people already love their jobs, how can you love it more? Well, this shows that that's possible. The other thing that's important is we need to make sure that we're providing access to patients on a consistent basis and providing them with exceptional care. And you can't do that unless you see enough people. So 97% of these people reported that they are meeting or exceeding the productivity standards that have been set by their organization or their own personal private practice. So in summary so far, we know the research is strong in residencies and fellowships build confidence, enhance skill development, enhance diagnostic accuracy, enhance clinical reasoning, and improve leadership. That's fantastic. But what about patient outcomes? Do patients matter? Or maybe because it's only 12% of people each year that go into residency, maybe it's just the cream of crop goes into residency. Maybe it's just time. Maybe an equivalent person gets the same amount of development in that same time period. Well, we always tell people you got to inform your practice by evidence. And without evidence, this is just a wishy-washy statement that, oh yeah, residency is awesome, fellowship's awesome. So we set out to look at just that. We looked at a study. We did a study in two parts. The first one we looked at, or the first part, we looked at patient outcomes. Do different levels of postgraduate training affect patient outcomes differently? The second part was looking more at how does a comparable person change in their patient outcomes over the same time period? So is it residency or is it something else? So to provide you with a little bit of detail, just so you can understand how we did this, we pulled the data from all physical therapists who provide outcomes data on their patients, which if you're watching this in, from some other state, all physical therapists at Physical Therapy at St. Luke's who treat orthopedic patients or who manage orthopedic patients submit data using the Focus on Therapeutic Outcomes system, which is a proprietary system, but it's consistent. And you were only excluded if you had fewer than 40 cases in that prior year. We split these groups into 4 groups. It was a fellowship trained group, a residency trained group, so people who were residency trained but not fellowship trained, people who were board certified without residency and fellowship training, and then people who had no board certification and were not residency or fellowship trained. All right, so part 2, we looked at the same group. This one was harder because we needed people to work with patients and have enough cases to be ranked with photo prior to starting residency and then post-residency. So it took us about 10 years to get 7 people to meet that criteria. And then we compared those people. So each individual person was compared with a case control. So we took names out of it completely. All of this was de-identified, just so everybody's clear. And we compared based upon the number of years of experience, how much experience, plus or minus 6 months, so half a year. And then the same starting point. So in other words, if somebody was starting out in the 40th percentile, meaning 40% of people got worse outcomes and 60% got better outcomes, they were compared with somebody at that same point. Whereas somebody who was starting at the 80th percentile, meaning 80% of people got worse or less change in their patient function over that time frame, versus 20% got better. They were compared with somebody at the same point. Okay, so we were comparing as many apples to apples as closely as possible. So this is what it looked like. We measured people at the starting point. And then we skipped a year, very much on purpose, because the people going into residency were in residency. The people who were not in residency were not in residency. And then a point 2 years later, which would be for the people who went through residency 1 year after residency, and for the other people, it would be just 2 years later. We found 7 people who were residency trained that had this amount of data, and 7 people who were not, who were case matched. For both of these parts, we looked at effectiveness, efficiency, and satisfaction. Effectiveness is the amount of functional change that a patient makes from beginning to end. Efficiency is looking at that amount of change over how many visits. So how efficient were you at getting the patient better? And then the last one is satisfaction. This is how satisfied was the patient with the care that you provided or the provider provided. So I will turn this over to Dr. Bradley for the results of the study and some additional information.
Thank you, Dr. Kareha. So up next, like you said, we're going to discuss the results of our study. And again, we kind of broke that down into two sections. So in part one, we're going to compare the outcome measures obtained by PTs broken down into highest level of postgraduate training. And then in part two, we will discuss the case control of the residency versus non-grads. Okay, so our first finding was that there was a 7-year difference on average in years of experience of residency trained individuals compared to other treating therapists in the St. Luke's network. Residency grads averaged just a little over 4.5 years of experience compared to others in the network at 11 to 12 years of experience. Up next was effectiveness. And as Dr. Kareha said, that's the rate and change of function at intake compared to discharge, with a higher effectiveness showing a greater improvement from the start of PT to the end. So we found that both residency and fellowship graduates had better effectiveness than their peers without this postgraduate training. Residency grads averaged between 5 and 9 points of improvement compared to their peers, while fellowship graduates averaged 11 to 15 points of improvement. Next up was efficiency. So again, we found that residency and fellowship grads achieved better efficiency to their non-peers or their peers without this postgraduate education. For this area, residency grads averaged about 3 to 7 points of improvement, with fellowship grads at about 6 to 10 points compared to their peers. And lastly was satisfaction. So each follow-up survey with photo contains a 9-item questionnaire to assess the patient's satisfaction with their therapist, the facility, and the results with physical therapy. In this area, we found that board-certified therapists, as well as residency and fellowship graduates, achieved higher levels of satisfaction. Pretty equal findings were found for both board-certified as well as residency-trained therapists, with fellowship grads achieving a score a few points higher on average. With this, we hypothesized that the improved satisfaction scores attained by board-certified, residency, and fellowship grads came from the confidence gained with obtaining board certification, but the improvements we found in effectiveness and efficiency related more to didactic learning and deliberate practice, as talked about by Dr. Kareha. Now on to part two. As Dr. Kareha mentioned, there were 7 residency grads that met this inclusion criteria, and they were again matched with peers at a similar level of years of experience, as well as a similar starting point to kind of make everything even. For this area, we found that residency grads had a 125% greater improvement in effectiveness and a 110% greater improvement in efficiency compared to their peers at similar level of experience without residency training. And again, this was over that 2-year time period of while the resident was in residency and 1 year after residency. So we noted there was a drastic improvement in the group that completed this residency program to the group that did not. So we found that our findings indicate that years of experience alone is not enough to produce meaningful change in patient-reported outcomes, as demonstrated by the greater change noted with the residency graduation group compared to the group that did not complete the residency. So to wrap up our overall findings of the study that we completed, compared to the groups that did not complete a residency program or a postgraduate training program, residency grads demonstrated greater effectiveness and improved efficiency, all while having, on average, 7 less years of experience. We did see further improvement with the fellowship program. However, we could not determine a statistically significant difference due to the small sample size of fellows, which Dr. Kareha is actively recruiting if you're interested. So our take-home message is that being a graduate of a residency program will lead to better patient outcomes in much less time. And we feel that this improvement made during a structured residency program will again lead to better patient outcomes, higher patient satisfaction, and this will contribute to the healthcare system as a whole, helping to decrease the overall healthcare burden. Okay. So up next, I want to discuss some additional benefits I found through research that we did not directly cover in this previous study. And I've broken this section down into 3 different areas. So first, we'll talk about the mentee, then the mentor, and then the organization as a whole. So up first, for some benefits for the mentee. So in a study of with 2,000 respondents, which included residency and fellowship grads, as well as those that did not go through these programs, the graduates reported a higher level of self-perceived clinical competence and clinical reasoning skills compared to those without advanced training. They also noted that they were more likely to become involved in mentoring themselves, so that they were able to take this expertise that they got through a residency or fellowship program and help to apply it to the future generation of PTs. As mentioned previously, one of the main highlights of a residency and fellowship program is the structured mentoring program. And this allows for one-on-one mentoring and deliberate practice, which have both been shown to drastically improve skills such as clinical reasoning. Further improvement is noted with active reflection and constructive feedback from the mentor. Upon graduation from a residency program, these residencies can provide a fast-tracked specialty practice, with research showing that 94% of residency graduates obtain board certification compared to 77% without this advanced training. Furthermore, this will also increase the likelihood of moving into leadership positions in their company, organization, as well as informal roles, such as being a resource of skills and knowledge to others in their clinic. Some additional benefits that I found for mentees. I found 2 systematic reviews that looked at the benefit of mentoring for both public health nurses and hospital-based nurses. These mentees reported that they had improved skill development and skill acquisition, again through deliberate practice and constructive feedback from their mentors. These mentees also reported that they felt that they had improved self-efficacy after working through a mentoring program. They noted that they felt increased pride in their work and had higher overall confidence levels after working with the mentor. And lastly, as Dr. Kareha mentioned about burnout, these mentees noted improved resilience, and they felt they had a better ability to deal with both workplace and emotional stresses. Now, we obviously know that the mentees benefit a lot from a mentoring residency fellowship program, but there's also some benefits that the mentors themselves get. Again, in that same study of public health nurses, mentors noted that they had increased overall job satisfaction. They've noted that they felt a higher level of commitment to their network. They reported better overall job performance, and they felt that they had enhanced career success. Mentors further noticed that they appreciated the challenge provided by taking a mentee, causing their own knowledge and skills to grow through reciprocal learning. This was found to be especially true with newer grads, as they had the most up-to-date classroom learning, but a more novice skill set, which was shown to lead to greater improvements for both parties. And lastly, mentors also reported that they had improved relationship with not only with their mentees, but with other mentors in their network that may be working in separate departments. They found that this helped to improve their reputation and standing throughout their network, again leading to additional opportunities such as moving into leadership roles and advancing their careers. And next, we're going to talk about some benefits that the organizations that have these mentoring or structured residency and fellowship programs can see. So one of the main ways that the organization benefits is through mentoring. One example of that is experiential learning, which allows residents and fellows to shadow with other providers throughout the network. This allows the resident or fellow to become better acquainted with colleagues that they may be working with and gain a deeper understanding of these professions. But It also allows the resident or fellow to share the scope and practice of physical therapy to those professions that may not be fully aware of what physical therapists can see, treat, manage, etc. Hospitals, organizations that had a mentoring program or a structured residency program also noted an improved work environment. This was especially true with mentees, that they noticed an improved work environment atmosphere that was created by their mentor. These hospitals that had a mentoring program also noticed an increased retention rate of their employees, leading to lower turnover and decreasing the cost of having to recruit and hire new employees. And lastly, it was found that mentors were able to help improve clinician autonomy, leading to improved confidence when treating patients and therefore increasing patient satisfaction. One interesting study that I found outside of healthcare was a 5-year study that looked at the benefit of mentoring new teachers into a school district. They found that this actually showed a positive rate of return over this 5-year time period for the organizations that implemented a mentoring program compared to the organizations or school districts that did not. Initially, they were just hoping to break even, but this study showed that by increasing the skill set in a much quicker time, they were able to generate a positive return over time. Overall, mentoring programs, such as those found in residency and fellowship programs, lead to more skilled providers, higher standards of clinical practice, and improved employee satisfaction for both mentors and mentees, leading to increased workplace pride and higher retention rates. This study on excellence and value in physical therapy residency education was very recently published in November of 2024. And again, they sought to determine and define excellence and value in physical therapy residency education. This was a multi-site qualitative study examining exemplary residency programs throughout the country. These findings were reported by the participating residency program, which included residents, mentors, faculty, and administration. For value, they broke their findings down into 3 separate areas: individual, organizational, and societal. So at the individual level, these respondents reported that residency graduates provide an accelerated path to specialty practice. It improved clinical outcomes. It helped to prepare the residents for future and continuous learning. It was noted to increase their future career opportunities, and it served as a key source for professional network building. Now, an interesting note is that the authors found that residency training alone did not just make one an expert, but rather it taught adaptive expertise, which helped to advance the clinical reasoning and skills and condense several years of experience into a shorter, more intense period of learning. They found that these benefits also extended to other staff that work with residents and led to a more attractive work environment when looking to hire in the future. So some of the findings at the organizational level, kind of mentioned, was these clinics and facilities that had a structured residency program found that they had better recruitment and retainment of highly motivated individuals, not only just bringing on new residents. They felt that these clinics had improved patient satisfaction to their clinics without this structured residency program, and they felt that overall it helped to improve their standing throughout their community. And lastly, at the societal level, they felt that improved level of practice throughout their clinics, which again helped to increase their public recognition. And they felt that these structured residency programs improved societal health through increased access to high quality specialty care and improved clinical outcomes. This study was the first to examine excellence and value of physical therapy residency education on the national scale, and much like our findings, points towards the benefit of postgraduate education and how it can help to advance the field of physical therapy. And our last topic to discuss for today is a survey that was sent out by Dr. Kareha to all employed physical therapists and the Physical Therapy at St. Luke's Network. This survey was sent out to kind of judge the benefit and pros of what the residency and fellowship programs can offer. So overall, 82% felt that the residency program positively benefited their clinic, while 92% felt the same way about the fellowship program. We further broke down these findings into 3 areas: the clinical benefit for the therapist, professional development factors, and the improvement noted at the clinical level. So first, for clinical impact, some of the reported findings were improved clinical decision-making, it leads to more evidence-based practice, and it leads to more efficient outcomes, especially with complex cases. From the professional side, graduates had increased confidence both when interacting with their patients and with their peers. It was found that these programs helped to improve networking opportunities, and they felt it helped to develop future leaders both in and out of the clinic. And lastly, for the clinic itself, they found that it helped to raise the standards of the entire clinic. It made for a more collaborative environment, leading to a culture of continuous learning, and it improved relationships with referring providers throughout the network, leading to improved patient care and satisfaction. So our take-home message for this presentation. Our findings indicate that these postgraduate programs help to demonstrate superior patient outcomes. Residency-trained clinicians achieve better effectiveness and efficiency in treating patients with 7 fewer years of experience compared to their non-residency-trained peers. The case control portion of our study showed a 125% greater improvement in effectiveness and a 110% greater improvement in efficiency. Research has shown that this leads to accelerated professional development. Residency programs fast-track clinical expertise through structured mentorship, deliberate practice, and specialized training. This is supported by data showing improved clinical decision-making, diagnostic accuracy, and more effective treatment of complex cases. But these benefits extend beyond just the individual. The impact of residency programs creates a ripple effect which benefits the organization through improved work environment and clinical standards, the mentors through increased job satisfaction and reciprocal learning, and the profession as a whole through advancement of clinical practice and standards. Last, we just have our references here. Anyone is interested?
If you have any questions, please feel free to unmute yourself and ask, or you can type them into the chat.
Go for it.
Do you know what you found in your research? Do you have a recommendation to go out there on, and this is specifically for residency, do you have a recommendation for someone looking to get into residency as to when they should get into it? Meaning, right after they graduate, wait a year, wait 5 years? What do you see is most beneficial?
So I'll preface this with there's no good evidence out there determining what is better. So the answer that I'm going to provide is my own personal experience and the feedback that I've received and anecdotal evidence from a group of about 20 different program directors from around the country. In true profession or professor of fashion, I'm going to say it depends, but the positive of going into a residency program immediately after school is you have less time to pick up bad habits.
And which is just like medical.
Yes, which matches the medical model, which is actually one of the reasons. So you have less chance of doing harm and more chance of getting the right information early on. In the one thing that's different about physical therapy residencies is because they're optional, you are working, you are seeing patients, you are managing your life earlier with while at the same time going through a residency or not. So a lot of the things that we, again, this group of about 20-ish program directors from around the country have found is generally people do best with at least a few months of experience, just from a stress level. So they're not learning to have their usually first real full-time job, living on their own, managing bills, managing everything that life has to throw at them at the exact same time as starting a relatively intensive program. The other side of the argument, though, is waiting a long time. The longer you wait, just statistically, you run into issues. Life throws a lot of stuff at you. And you are less likely to do it the longer you wait. As far as fellowship is concerned, generally, it usually takes at least 1 to 2 years to become a specialist if you go through a residency, and if not, it usually takes about 5 or 6 years. So, those people anywhere from 3 to 25 years after starting practice is fantastic, and even beyond that can be fantastic. Sure.
Any other questions?
Well, if you do have any further questions, please feel free to reach out to either Dr. Bradley or to myself, and we'd be happy to answer whatever questions you have. Thank you very much for attending, and please make sure you complete the quiz and the course evaluation. We love to get feedback and always make things better. And then you will get your CE or CME credit. Thank you very much.